DSM-5 made a significant structural change, moving obsessive-compulsive disorder out of the anxiety disorders chapter entirely and creating a new category, obsessive-compulsive and related disorders. This reclassification reflected growing evidence that OCD shares a distinct underlying pattern, intrusive thoughts paired with repetitive behaviors, with several other conditions that had previously been scattered across unrelated diagnostic categories. Obsessive-compulsive disorder is characterized by obsessions, intrusive, unwanted, anxiety-provoking thoughts, images, or urges that the person recognizes as excessive or irrational but cannot simply dismiss, and compulsions, repetitive behaviors or mental acts performed in response to an obsession, aimed at reducing the resulting anxiety or preventing a feared outcome. The core problem maintaining OCD is that compulsions provide only brief, temporary anxiety relief, which powerfully reinforces the compulsive behavior through negative reinforcement, creating an escalating cycle that ultimately increases rather than decreases the disorder's overall grip. Neuroimaging research on OCD consistently implicates hyperactivity within corticostriato-thalamocortical circuits, a loop connecting the orbitofrontal cortex, involved in monitoring for errors and threats, the caudate nucleus and striatum, involved in habitual and repetitive behavior selection, and the thalamus, which relays this signaling back to the cortex. This circuit hyperactivity is theorized to produce both the persistent, difficult-to-dismiss sense that something is wrong or dangerous, and the compulsive, habitual behavioral response aimed at resolving that sense, explaining why both cognitive behavioral therapy and serotonergic medications, which both affect this circuit, are effective treatments. Body dysmorphic disorder involves persistent, distressing preoccupation with one or more perceived flaws or defects in physical appearance that are not observable or appear only minor to other people, accompanied by repetitive behaviors, excessive mirror checking, skin picking, seeking reassurance, or comparing one's appearance to others, performed in response to the appearance concerns, closely paralleling OCD's obsession-compulsion structure, but focused specifically on perceived physical flaws. Body dysmorphic disorder carries substantial risk of significant social and occupational impairment and elevated suicide risk, often going unrecognized as clinicians and patients alike may focus on the specific appearance concern rather than the underlying disorder pattern. Hoarding disorder involves persistent difficulty discarding or parting with possessions, regardless of their actual monetary value, driven by a perceived need to save items and significant distress associated with discarding them, resulting in accumulation that congests and clutters active living areas to the point of substantially compromising their intended use. Unlike classic OCD compulsions, hoarding behavior is often experienced as less distressing to the person engaging in it and more distressing to family members, and hoarding shows notably poorer response to standard OCD medications, requiring specialized cognitive behavioral approaches targeting decision-making and emotional attachment to possessions specifically. Trichotillomania, recurrent hair pulling resulting in noticeable hair loss, and excoriation disorder, recurrent skin picking resulting in skin lesions, are body-focused repetitive behavior disorders included in the OCD-related category, both characterized by repeated attempts to reduce or stop the behavior despite ongoing engagement in it, and both often serving an emotional regulation function, providing a sense of relief, gratification, or sensory satisfaction rather than resolving an explicit anxious obsession as classic OCD compulsions do, which has implications for how each condition is best treated. Exposure and response prevention, a specialized form of cognitive behavioral therapy, is the gold standard evidence-based treatment across the obsessive-compulsive spectrum, involving systematic, gradual exposure to feared or triggering situations while actively preventing the accompanying compulsive or ritualistic response, allowing the person's anxiety to naturally decrease through habituation rather than through compulsive relief, and disconfirming the belief that anxiety will remain unbearable indefinitely without the compulsion. This core approach is adapted specifically for each related condition, targeting mirror-checking behaviors in body dysmorphic disorder or discarding practice in hoarding disorder. The obsessive-compulsive spectrum reveals a shared underlying pattern, intrusive thoughts or urges paired with reinforcing repetitive behaviors across a surprisingly wide range of conditions once considered unrelated. Recognizing this shared structure has both clarified the science of these disorders and improved access to the specialized, evidence-based treatments that effectively address them.